Thank you, David. Thank you also to the organisers for the wonderful invitation to speak today. It's been one of the most special conferences I've ever been to, with that meeting of the minds between families and patients and scientists, so thank you very much. So I'm going to talk to you about Li-Fraumeni syndrome, but through the lens of paediatrics. So most of my talk is about children under the age of 16, and I'll show you why that's my focus when you see where I sit in the world. So I wanted to give you, first of all, an introduction to the Aussie context. I added the koala in case the accent wasn't enough, and then give you a little bit of an audit of what we do in Sydney with regards to Li-Fraumeni testing in children under the age of 16. And then I was going to whiz you through a couple of related studies. One's a review that we've just completed looking at attitudes towards testing children for TP53 mutations. One's a qualitative study asking families and young people what it was like if they had genetic testing when their child was under 16. And then I'm going to change tack slightly and talk a little bit about what might be the role of family history in childhood cancer survivors. And I'll tell you what's next for us in Sydney. So just an introduction to the Aussie context. This is the closest I've ever done in terms of how similar we are. When I go to the US, they have way too many people, and when I go to Europe, we're the size of 27 European countries, but we're actually really similar in terms of size, in terms of population. We still win as being the country with the lowest population density in the developed world, but you're very close behind. But very similar healthcare systems as well. So I hope what I had to say about what it's like in Sydney has a lot of relevance for people in Canada and more broadly. So where I sit, I run the Behavioural Sciences unit in the Kids Cancer Centre, and that's why I have quite a paediatrics focus. We do work across a whole spectrum of things to do with children and families with serious illnesses. And one of our streams is in ethics and genetics, and I have to admit that's the one that's closest to my heart. And so today I'm really going to focus on this particular area around the psychological impact of genetic testing for children for various health conditions. I just wanted to thank my lovely, lovely team, and particularly the ethics and genetics team, and Lauren and Brittany in particular, who've provided a lot of data and support for this, as well as Kathy Tucker, our clinical geneticist, and Mira Warby, our genetic counsellor. So it's really exciting times to be working in children's cancer. There is so much happening, and particularly if you're interested in genetics, because I think the thing about children's cancer genetics is that it has all the interesting elements of adult genetics, but it's got more complexity and higher stakes. And as a psychologist, there's nothing I love more than complexity. So the first thing I wanted to tell you about is what we do in Sydney in terms of testing children. And so we did an audit of all of our children's cancer genetic appointments over the last 5 years. So we did this because paediatric cancer genetics is really an evolving field, and it has its own unique challenges. And we thought it would be helpful for genetic counsellors to get a sense of what are the issues that most concern families when they come for cancer-related genetic testing. So our research questions for the audit were, what are the main issues that are discussed when a child is brought in to consider cancer-related genetic testing? And then for this talk, we also looked at whether the issues are different for children or families considering testing their children for TP53. So the first question really was, why did they come to clinic? We had 70 genetic testing or counselling appointments over the last 5 years for children. 11 of them were considering TP53 mutation testing, amongst others. So you can see here the reason for referral for all other types of cancer-related genetic testing. About half of them were because the child already had cancer. But in LFS, people considering LFS, most of the children in the sample had already had at least one cancer. So these are the 7 issues. When we looked at all of the 70 consultations, these were the 7 key genetic counselling issues that came up. I think they'd be relevant and familiar to all of you. And what was interesting was that families who were considering TP53 testing actually raised more issues per appointment than the other families. So they raised at least a minimum of, or a mean of, nearly 5 issues out of the 7 in each appointment. And so what were the issues that genetic counsellors were managing in those appointments? So for the other families, the most important thing was just trying to cope with uncertainty and managing parents' distress. And for our LFS, potential LFS families, you can see there that they raised all of the issues more often, but particularly the one that was significantly different, even with quite a small sample, was this one around planning for screening and surveillance. So obviously that's in the forefront of families' minds when they're considering testing their children. So what do we think about testing children for LFS? This is obviously a little bit of a controversial topic, and so we did a systematic review looking at what people think about this issue. And so the question really is, should we even offer genetic testing to children? And I think my principle in everything I do is, I guess, first we should listen to patients and parents and also their clinicians. And I have had an absolute passion for this topic for a long time, and I've probably written too much about it, but certainly I've looked extensively at what the psychological impact is for doing genetic testing in children for multiple health conditions. I've asked parents, or looked at what parents think about genetic testing for children, asked young people and adolescents in particular, and also looked at what young people and adolescents actually understand about genetic testing, because I think that's important if we're thinking about offering it to them. So for this study, we wanted to particularly look at what do children themselves, parents and clinicians perceive to be the advantages and disadvantages of testing children under 16. So we did a systematic review and screened 923 abstracts and found 8 articles that had been published on this topic. So 2 of them were actually interviewing young people, 5 interviewing parents, and 1 surveying clinicians. And here are the perceived advantages. So if we look at what children think might be the benefits for them of having testing, they looked at potential for increasing their understanding about their cancer risk and where the cancer came from. They liked the idea of reducing uncertainty and potential anxiety. And they also had quite an altruistic bent in the studies that were published, wanting to contribute to medical research and providing benefits to other family members by them having testing. For parents, they had more perceived advantages across the studies, and particularly they were interested in how that might enable their future planning, for example, for further children. They were interested in how it would inform the child's health management, and they liked the idea of demedicalising their child if they tested negative. And for clinicians, they were also concerned about similar issues, but also focused on the potential for access to targeted surveillance for children. But of course there were concerns, and there should be, because these are children and we're doing something very important with them. So young people generally were very positive about having testing or having had testing, but they were aware of the issues around decreased privacy and insurability, and several of them didn't like the idea of the actual blood test. For parents, they were worried about potential negative impacts on children, and they were worried about taking away their child's right to not know their mutation status. And for clinicians, they were focused a little bit more on the potential lack of proven medical benefit of testing, and also worried about family anxiety. So the next question then is, what is it like for families going through genetic counselling and genetic testing if they have a child who is at risk of cancer? So this was a really in-depth qualitative study which is ongoing, so there's a little bit of data to share with you. And the first question was really, what do families describe the experiences like when their children go through cancer-related genetic testing or counselling? And how satisfied are they with that service if they do go ahead? So to date we've interviewed 28 families, and in most families we've tried to get the parents as well as the young people, and of those 28, 2 of them were considering LFS for their child. So generally out of the 28 families, what was done? Four families decided not to test their child after counselling, but the other 24 went ahead with testing. And of those, 16 other family members were then tested after the child was found positive. So in terms of their emotional descriptions, there was quite a lot of distress around the decision-making process and what it was like going through that, particularly if their child had also had a recent cancer diagnosis. There was some guilt described, and interestingly, not just guilt for parents, say, passing on the illness, the syndrome to their child, but also people who were found negative also described a feeling of guilt. But also a lot of relief. And interestingly, yes, people whose child was then tested and found to be negative experienced relief, but actually some people who tested positive also found relief in at least knowing the answer to what had happened in their family. But interestingly, despite the distress, we only asked this question to 24 of the families. 23 of them said they had no regrets of having gone ahead and having testing with their child. So in terms of how satisfied they were, 22 out of the 24 families said they were really highly satisfied with having gone through the process, and only 2 said that they weren't as satisfied with having gone through the service. Here's the genetic counselling satisfaction scale, and you can see they're pretty high scores for both parents and young people. But interestingly enough, while they may be really satisfied, many families were still quite confused about what had happened. They hadn't really processed it, particularly if their child was having cancer treatment at the same time. So while they were happy that they did it, they didn't understand a lot about the depth of what happened and what the future implications might be. And I love this quote from this mum whose child is now 26, who said, I remember what I felt, but I don't remember the gene. And I think that's a really good description of some of the family's experiences. So zooming in on those 2 families who considered LFS for their children, we interviewed one mother whose child had a stage 4 neuroblastoma, and both mum and dad had had a previous cancer, and they both had a strong family history of breast and ovarian cancer, and the child was tested negative, and that was one of the examples where they were actually disappointed that they didn't get a result because they had no clear answer to why their family was affected so strongly. We also interviewed a father whose child was diagnosed with leukemia and then a bone tumour. His mother had died from breast cancer when he was 1. And again, he had a negative result and a similar feeling of upset that they hadn't known what the cause of the cancer in that family was. But still, that father described really the advantages outweighed the disadvantages, whatever the test result was. So changing tack a little bit, I wanted to just mention in the last few minutes another issue which is around family history and whether or not we should be taking family histories in childhood cancer survivors. So here's the paper if you want to read a little bit more. So why would we screen for family history in survivors? Because we're now in the era of genetic testing and we can genetically test everybody. And certainly in the past, family history could have been a really cost-effective way to identify at-risk families. But why would we do it now when we have access to all of this screening? Well, in Australia alone, we have at least 20,000 young people who've survived cancer. And at the moment, it's not possible to offer them all screening. And of those, there's some suggestion that about a third of them might warrant a genetics assessment based on their family history alone. And why would we screen them now if they had their cancer 10 years ago? They may have been diagnosed before the genetics revolution, so their family history may have never been looked at, or their family histories might have changed over time. So as they grew up, more cancers appeared in the family. So our question was for this study, could reassessing family history in long-term survivors of childhood cancer actually identify families at risk for LFS? So we collected self-reported family histories from a large number of survivors, and these were reviewed by our genetic counsellor to see whether any of the families met the Chompré criteria for TP53 testing. We recruited 648 survivors, and you can see there how many family members overall they reported that were affected by cancer. So of that 648, 33 or 3% were referred to genetic counselling at any point since their cancer diagnosis, and 17 of those were referred for a suspected LFS. But when we screened them, actually 11% or 69 of the families actually met Chompré criteria. And so the question is, did we miss 52 at-risk families? And that's only a small sample of the survivors that are out there. So obviously the study has some limitations, but both of these I think actually suggest we might have there might be more families out there, because obviously we only interviewed survivors, and the most aggressive cancers, those children had passed away and we didn't look at their family histories. And also it was a self-report family history. But surely now that we're in, the genetic age and everyone knows, surely we're catching them now, right? So the next study I just wanted to briefly mention, and I have to thank David, who gets thanked in every talk, but thank you for your contribution to this particular paper. We decided to look at whether doctors, including family physicians and also oncologists, whether they ask their patients about their family histories, with the expectation that they would all say, yes, of course we do. So the core question was, how often do providers take family histories when they're caring for a childhood cancer survivor? So for primary care providers, we interviewed 46 GPs who had a childhood cancer survivor in their practice. And only a third said that they regularly assessed family histories. And concerningly, only 17% said they would ask a childhood cancer survivor about their family history any more frequently than any other patient in their practice. So we thought, well, at least the oncologists will do it when they come back to long-term follow-up clinic. But unfortunately, they also didn't do it frequently. So only a quarter regularly asked survivors whether there was any change in their family history or did an assessment at all. And most of them relied on the patient bringing it up. And that's a real concern if you're thinking about young people who aren't sort of yet active and advocates for their own health. So my overall conclusions, I guess, is that LFS families considering paediatric testing may need extra genetic counselling supports while they're going through the process. The impact of genetic testing for families appears manageable if they decide to go ahead. Families appear to really want genetic counselling and are satisfied if they get a really good service, but yet clinicians overall may be quite hesitant about going ahead. And the other question, I guess, was could we consider family history screening as standard practice in our long-term follow-up clinics and potentially asking GPs to do the same. So what does the future hold? In Australia, our focus will be on our latest big study, which is looking at genetic service needs in childhood cancer survivors. And then we've launched a really enormous personalised medicine program. Some of that includes offering whole genome sequencing for all children at diagnosis. And then we have a really big $80 million program called Zero Childhood Cancer, which is offering personalised medicine to all children at high risk of cancer across the country. And then just to finish, I thought I'd say with the Zero program, what they also offer is patient-derived xenografts for every child. And what that is essentially creating a cohort of mouse avatars for every patient. And they pre-test the drugs for every patient on this mouse cohort if they can. And so being the psychologist, this of course fascinates me. So we've done a very large acceptability study to see what people think about mouse avatars. And we've recruited more than 1,500 people from the general community and adult and child cancer survivors and also parents. And just to give you a really little snapshot of the data in the last minute, we asked them how much they'd be willing to pay for mouse avatar. And you can see there they're willing to pay quite a lot considering there's no evidence yet that this is going to improve the child's outcome. Survivors' parents and childhood cancer survivors are willing to pay the most, and then people in the general community less so. And the other slightly controversial question that we asked them was, how many mice would you be willing to sacrifice per patient? So this was an interesting and kind of awkward question to ask, but I think it's important. And you can see there again that the survivors' parents and childhood cancer survivors were willing to sacrifice an awful lot of mice. 60% of them said they would use more than 1,000 mice per child. Much less so if it was a community member who hadn't been affected by cancer. So that will be an interesting study to see how that goes. And I now wish I asked about zebrafish because that seems to be the new thing. One of our family members yesterday said they loved the idea of having an army of zebrafish avatars. So now I feel like I have to do the whole thing again for zebrafish. So in the future, we're looking at assessing economic impacts of genetic testing in children and personalised medicine, and also developing education resources for families, because our service needs study really has highlighted some needs for education and support. I also just wanted to finish with a big thank you to Andrea Patternard. I'm sure many of you know her, and she passed away recently. She was a great colleague and a wonderful mentor.